Welcome everyone to the eMedica MRCGP AKT High Yield Revision webinar for the July 2025 exam. So the format today, we're going to have sort of three sections, if you like. Part one, we'll do 5 interactive questions. I'll give you 55 seconds to look at each question. Then I'll launch a poll, use the poll to select the answer. Part two, I'm going to get you to do a timed mini mock exam. So 10 questions, they'll all go one after the other. I'll wait till you've looked at all of them, and then we'll go through answers, explanations, and teaching. And then part three, we'll talk about revision planning, how to make the most of the time between now and the exam. We're 7 weeks out, okay? And then there'll be time for a Q&A at the end. So use the chat as you've already been doing to get involved in the discussion. If you've got questions that you'd like myself or the faculty to answer, please use the Q&A for that. Okay, good. So we're going to go straight into part one, which is interactive questions. I'm going to launch the first question now. Once you see it, you won't see me until I launch the poll. You'll have 55 seconds to look at it, and then I'll launch the poll. Here we go. Great. So time's up, and I can see that there's a split between A and C. C is the most popular answer. Just under half of you picked C, and then about a third of you picked A. These are the two most popular answers, although all options have been picked by multiple people. Okay. Now, any question in the exam that has a picture, look at both the picture and look at the scenario. Sometimes there can be useful clues. So if you look at the scenario, the thing that's useful here is that they're 38 years old and they're having an annual check as part of their work. You can see that most jobs don't need an annual health check. And even those that do, even few of those require an audiogram as part of that. So that could be a useful clue, right? And then if we look at the picture, you can see that this one is quite challenging because there isn't a key. It's not labeled what we're looking at here. That's the test, okay? So you can see that this is mostly in the normal range. And you can say this one, there's some significant hearing loss, especially in the higher frequencies, okay? So the correct answer is A, that the hearing in the right ear is mostly in the normal range. That's because the right ear, in standard denotation in an audiogram, if it's in color, will always be in red. Easy way to remember it, refer red, refer right, okay? And then the left ear is in blue. That's the standard color coding of audiograms, okay? So what we've got is that, if you like, this is the line of normal, all right? Anything at 20 decibels and above is in the normal hearing range. Anything below that, so here we've got about 25, that's very mild hearing loss. Down to about 40 is still mild. And then we get to moderate hearing loss, 40 to 60. Once you get below that, it's getting more severe. 70 plus is really significant, okay? And then when you get down here, you sort of profound hearing losses down here, all right? So what we can see is the right ear, it's in the normal range all the way up to here. Even this is right on the border, just right at the end, at sort of coming up to 7 kilohertz, there's very mild loss. Whereas if you look at the left ear, you can see there's mild loss even at low frequencies, and then it gets to moderate loss in the higher frequencies, okay? So C was the most popular answer, that this is consistent with a conductive hearing loss in the left ear. If that was the case, what you'd see is that there'd be reduction in air conduction in the left ear, shown by the blue crosses, But you'd also expect to see another blue line up here in the normal range showing bone conduction. Bone conduction is always shown with brackets. Bone conduction isn't shown at all for the left or right here in this audiogram. That's quite common in a sensory neural type hearing loss. They often don't bother showing bone conduction because we don't really care about it. Okay. Whereas in a conductive loss, they'll generally show both the bone conduction and the air conduction. And you see that gap that shows you that there's a conductive loss. I'll show you an example of it in a minute. Okay. So this is an audiogram showing conductive loss. Okay. So look, brackets will be used for bone conduction, either square or triangular brackets. Air conduction, they'll have either a cross or a circle. It's standard to use a circle for one ear and a cross for the other. Okay. Similarly, for color coding, where it's in color, it's standard to use the right will be red and the left will be blue. Okay, so in a conductive loss, here we've got an example of a bilateral conductive loss. So do you see, the blue is left, the red is right, the brackets is the bone conduction. Both right and left, bone conduction is normal. And then both right and left, you've got some loss in the air conduction. That's these ones, okay? Circle and cross. Just remember, air passes through a circle. Sensory neural hearing loss, typically they won't bother showing the bone conduction. You'll just show the air conduction. So this, anyone know what type of hearing loss is shown here in this audiogram here? Type into the chat. So the one that's shown here, this is very typical of presbycusis, the hearing loss of old age, where the high frequencies get lost. If we go back here, okay, similarly, you can get, other types of hearing loss that might be, what kind of thing might be more common in someone this age? It's 38. When might we see presbycusis? Patients in their 60s, 70s, and so on, right? What kind of engineer might they be that they have to have a health check? They might be working in an environment where there's a lot of loud noise, okay? And so noise-induced hearing loss is the second most common type of sensory neural hearing loss. What typically happens is there will be set frequencies that are lost. So in this case, this patient, they've got loss here, right? Okay. It happens to be at high frequencies. You might see another one, depending on their job, that the loss is here, and then it gets better again when you go outside of that. Okay. Presbycusis is commonly bilateral. Let's move on to question number 2, men's health. Now, this is an example of a two-step question, which adds challenge to the question. You can see that the mark is about the most suitable management option. But if you want to have a good chance of getting that right, you first need to look at all the information provided, and there's a lot, and work out what's the likely diagnosis. Now, that could be in a different scenario. They could give you the same information and say, what's the most likely diagnosis? So let's double the learning and answer that question too. Type into the chat what you think is the single most likely diagnosis based on the information that we've got. And then you've selected on the poll what you think the right management is. Okay. In terms of the poll, there's an even split between B and D in terms of what people have picked. They're the two most popular answers. So let's see why that might be. So we look at what people have put for what they think is the right diagnosis. We've got torsion, orchitis, prostatitis, epididymitis, non-STD epididymoorchitis, and so on. Okay, so various different diagnoses, but the most popular one is epididymitis or epididymal orchitis. Okay, that's the most popular thing that people have typed. And so epididymal orchitis is the likely scenario given this. Okay, in terms of the right answer, the correct answer is D. Okay, treat with levofloxacin for 10 days. This bit's important. I'll come back to the other options and why people might have picked them. But if we pick out some of the important things, and this is one of the things when you're reading the question, try to pick out keywords, key symptoms, key signs that can make a difference, that can help you separate options. So you can see that this patient has got unilateral scrotal swelling and pain, 4-day history, all right? No trauma, not been sexually active in the last month. That's important, not been sexually active, but has recently had a UTI. And then there's mild tenderness. This bit's really helpful. Pren sign is positive. Type into the chat, anyone know what Pren sign is? And what's the significance in this case that it's positive? So Pren sign is that when you elevate the scrotum, thereby elevating the testes, it relieves the pain. And this is typical of epididymal orchitis. In torsion, will elevating the scrotum relieve the pain? No. In fact, in torsion, it tends to be exquisitely tender. If you try to elevate it, they'll just scream. It's usually really, really painful, but it will usually not make a difference to the pain. So the fact that Pren sign is positive makes torsion less likely. Similarly, the age also makes it less likely. Torsion we typically see more commonly in a younger age group. Okay, right, now let's look at then how epididymal orchitis presents. So it has this gradual onset, it's painful, there's tenderness on a palpation, there'll be a swelling there, there'll be erythema overlying, and Pren sign is usually positive. So when you elevate the testes, it relieves the pain. Now, if someone with epididymal orchitis was sort of septic looking, very high fever, feeling really unwell, we might need to admit them for IVs. But otherwise, we can either treat in GP or refer to have them seen by GU medicine if they can be seen within 24 hours. In a lot of places, they're just not going to be seen that quickly. So we'll deal with it in GP. And you treat based on the likely course. So if they've been recently sexually active and maybe they've got symptoms that make you think of things like gonorrhea, then something like ceftriaxone, okay? You might add to that doxycycline or azithromycin. If they've not been sexually active or they're low risk for STI, and you think actually they're more likely to have an enteric organism, this patient recently had a UTI, that fits for this patient, okay? Then either ofloxacin or levofloxacin would be useful. Both of these are long-term treatments, okay? So ofloxacin is a 2-week course, levofloxacin is a 10-day course. So I'm going to show you something really important. The importance of reading the question we already know about. By this stage in your preparation, that's something that you will have already practiced lots. So I want to highlight the importance of reading carefully the answer options and how small things can make a difference. So look, those that picked A, if you thought it was torsion, this would be logical, but this doesn't fit torsion because Pren sign is positive. Okay. If he'd been recently sexually active or he had discharge or things like that, then you might think about option B because that would fit, all right, if it was an STI. Remember, I mentioned that the treatment options for enteric are ofloxacin or levofloxacin, but they're both long-term. So a common mistake is people that pick C, they see ofloxacin 200 and they get that far and they select it. It says single dose. A single dose won't do anything. It's a 2-week course you need, and it's 2 weeks twice daily. So you need 28 doses. 1 dose is going to do nothing. Okay. Option D is right because not just the right drug, but it's the right dose. And then E, azithromycin, again, doesn't quite fit for this patient. If you thought it was an STI, that might be an option. Okay. Let's move on to number 3. Okay, great. So the split here is between A and B. All right. And again, there's 2 steps to this question too. Okay. So again, we're looking at the management according to the FeverPAIN criteria. So the first step is calculating the FeverPAIN score. Type that into the chat. What is this patient's FeverPAIN score based on the information we've been given? So we've got from as low as 0 to as high as 4 are things that people have put into the comments. All right. So this patient's FeverPAIN is actually 3. All right. And that's why the right answer is B. Offer a delayed script for penicillin. About half of you got that right. The split of those that didn't pick this one, a lot of you picked A, advised no need for antibiotics. Now that would be the right answer according to the guideline if the FeverPAIN score was 0 or 1. So those of you that you thought it was 0 or 1, I can see why you picked A. So do you see there's the knowledge side, knowing the FeverPAIN score, and then there's the technique, reading carefully to pick out the information to actually get the right score. Okay, so let's look at why they get a score of 3. So the fact that they have come within 3 days of symptoms, the A is attending rapidly, 3 days or less from onset of symptoms to them having come to see you. So you can see they've come within 3 days. It's been 2 days. So they get a point for that. All right. Having a fever in the last 24 hours, that includes self-measured or self-reported fever. So, mum measured it as 38.1 earlier. So although they're afebrile now, the fact that within the last 24 hours they had a fever, they still get a point for that. So that's 2. And then the tonsils being inflamed, that's what the I is, inflamed tonsils, even though there's no pus. If they had pus, that would be another point, okay? That, then it would be 4. But without the pus, there's no pus. The fact that the tonsils are inflamed, they do get a point for that. So that's 3, okay? So 2 or 3, consider a delayed script. 0 or 1, no need for antibiotics because the likelihood that it's bacterial, that it's strep, is very, very low. 4 or 5, there's a high probability, you'd start antibiotics then. You'd think about that then rather than a delayed script, okay? So because this patient's 3, a delayed script is the right answer, okay? So this is FeverPAIN. You score 1 point for each of the following. So fever in the last 24 hours, that includes self-measured or self-reported. P is for pus on the tonsils or the back of the throat. A is attending within 3 days or less from onset, i.e. attending rapidly. I is inflamed tonsils. And N is no cough, no coryzal symptoms, i.e. if they have either a cough or they have a runny nose, they don't get a point. If they don't have a cough and they don't have a runny nose, blocked nose, cold-like symptoms, then they get a point for N. So 0 or 1, almost no probability that it's going to be bacterial, therefore no antibiotics. 2 or 3, moderate probability, so you might consider it a delayed script. 4 or 5, high probability, think about starting antibiotics that day. And if they've got no allergies to penicillin, then first line is Pen-V for 10 days. If they're allergic, then you would use either clarithromycin or erythromycin, and those are 5 days. Okay, let's look at the admin domain and health records. Okay, and I'll stop you there. So the most popular answer is E, followed by A. So either ask him to request under Access to Health Records Act or advise that he can't access because of confidentiality, which doesn't stop on someone's death. It remains after death. So the correct answer is E. So well done. That was the most popular answer. So well done. And the reason for that is that he wants to access someone else's records who's passed away and he's got a legitimate reason. He's the next of kin, the executor of the will, and is worried about negligence. Okay, so E is the right answer. So 3 important bits of legislation in relation to health records for the admin domain. So the Data Protection Act 2018 is what we would use if we wanted to access our own information. You put in what's called a subject access request if you want access to your own information. If a company wants to access information on their employees, usually in relation to occupational health matters, then the Access to Medical Reports Act covers how to do it, when they can and can't do it. And then if someone wants to access someone else's record who's passed away and they have a legitimate reason, so they're either the next of kin or the executor of the will, or have permission from one of those people, and a legitimate reason to do so. In most common situation is where they think that there's negligence and they want to pursue legal action, then they would apply under the Access to Health Records Act 1990. Right, let's move on to the evidence interpretation and look at a data interpretation question. Here we go. Okay, great. So most people got this right. The correct answer is D, Doncaster. Of those that got it wrong, almost everyone picked B, Bradford. So let's look at why that might be. So if you look at the question, it's asking for the worst mortality rate, specifically for women under 75. So the first thing is to make sure you're looking at the right line. So we've got here different areas that are part of the Yorkshire and Humber region, which is part of England. Okay. Within that, you've got mortality rate from all causes. And so if it just says mortality rate here, we've got a specific age group, but no specific cause, then that's all causes. That's what mortality means, is death rate. If it doesn't specify a subset, like cardiovascular mortality, which is what the bottom 3 are, okay, then all cause mortality, they'll drop the all cause. That's mortality means the same thing, all right? Whereas sometimes we can look within this and there might be a subset that we care about. Cardiovascular mortality, cancer-related mortality, trauma-related mortality, infant mortality, neonatal mortality, and so on, okay? So here we're looking at all-cause mortality, women under 75. So you can see once you find that, got female here, then we just care about this line. And the worst mortality is the highest number. So the highest number is in Doncaster. So why might some people have picked Bradford? Well, if you look at Bradford for persons, i.e. male and female all-cause mortality, Bradford is the highest. If you look at male, Bradford is the highest. Okay. If you look at female, but you're looking at cardiovascular disease only, i.e. a subset, not at all-cause mortality, then again, Bradford has the highest rate. So it would be looking at the wrong line that leads to people getting the wrong answer. And so there's no maths here, there's no calculation. It's just interpreting the data that's there. Now, if you've never seen one of these before, it might throw you a little bit. So spending a bit of time getting familiar with them, it just makes it a little bit easier. You'll be a little bit less scared when you see it in the real exam, because you're not going to get this exact question, but you're going to get data like this, or other types of data. If you know what to look for, you can quickly find the right line, and then it's just reading across. So worst mortality, the higher, the worse, right? A different question might ask for the lowest mortality. Okay, so type into the chat which area had the best mortality rate, so i.e. the lowest mortality rate for cardiovascular deaths in men under 75. Type into the chat. So you see, now we'll be looking here, cardiovascular deaths, men, and here we're looking for the lowest number because we're looking for the best mortality rate. And so that's going to be here, 89.7. East Riding of Yorkshire. Okay, they have the best mortality rate across all of these categories. All right. And not just this type of data interpretation, but prescribing data, incidence and prevalence of different types of disease, other types of public health data, mortality rates for infants, neonates, specific diseases, but also interpreting research. So the classical graphs and charts are also important. I'll show you some examples of real life data. So this is looking at different age bands in a surgery where I work as a locum and have done for 15 odd years on and off. This is looking at broad spectrum antibiotic prescribing in a specific surgery in London compared to the England average. This is called a quinary chart. It's looking at 5-year age bands and the distribution of different ages for male and female patients in a particular surgery in Manchester. This is looking at infant mortality. This is called a leaf plot. Looks at pre and post test probability. And this is a Kate's plot, a visual way to look at risk. Okay, so you need to be able to interpret all of these things. Right, so we're going to move on now to the next session, which is a mini mock. Before we do that, that type of learning where we do one question at a time, immediately followed by answers, explanation, understanding why the right answer is right, why the common answers that people selected that were wrong were incorrect, is how we do the teaching in our AKT masterclass webinars, which are coming up in a couple of weeks. And if you join any of the live sessions, you get access to the recording afterwards for a month for revision. So we have Statistics Made Simple, 4 hours. We'll cover 50 stats questions, 60 plus key stats topics, including all of those new style data interpretation, all of those graphs I just showed you. We'll cover how to interpret them. The organizational domain organized, again, half day, 4 hours, 50 questions, 60 plus key admin topics. And then High Yield Clinical Grammar 1 and 2, they run over 2 long evenings, 3.5 hours each, so 7 hours in total, 50 questions each day, over 120 clinical topics mentioned by examiners covered across the 2 evenings. Okay, so you can book them individually. So these are £125 each. These 2 together are £198, or you can book all 4 of them as a bundle for £299, so saving nearly £150. Okay, if you're not available on the days, the recordings are available. Those of you on our Pass Plus or Pass Guarantee program, you're already booked for all of these. Okay, so these are just some of the topics we'll cover in the stats webinar. And lots of people have gone on to master stats and get 100, 95, 90, really great scores. Okay. Again, these are some of the topics covered in the admin domain. Again, lots of people have found that it's helped them really understand these topics, which can be a bit dull to learn, but it's a nice way to do it, all the important topics, in one half day, and gone on to get 95 in admin, 95 in admin, 90 in admin, 95 in admin. And then High Yield Clinical Grammar 1 and 2. All of the topics covered here are topics mentioned by examiners in recent examiner reports. These get tested again and again. And we'll also cover a lot of picture questions, because that's an area that people often struggle with. Okay, so time to do the mini mock now. So here, I'm not going to launch any polls. You're going to see all 10 questions one after the other. The questions will move forward automatically every 55 seconds. So write down the question number and your answer at home on a piece of paper, and then we'll go through answer and explanations afterwards. Here Okay, well done. So time to go through the answers, explanations, and teaching. So there'll be no polls, okay? Just mark your own. You get 1 mark for each fully correct answer, okay? So question number 6. Very common to get a couple of drug calculation type questions. So one tends to be about cancer type pain like this, and one will typically be a pediatric drug dosage conversion or calculation. So what we've got is, we've got a patient who is taking morphine sulfate modified release 240 in total, 120 BD, so 240 milligrams in total, well controlled, but can't take orals anymore. This is a good candidate to change to a non-oral method, okay? In this case, we're picking a syringe driver, all right? So what's the most suitable dose? The conversion from oral morphine to diamorphine in a syringe driver is 3:1. So all you do is 240 divided by 3, that's 80 milligrams of diamorphine over 24 hours, okay? So if we go to the calculation, they're on 120 BD, so that's 240 in total. The common mistake is people miss the BD. So sometimes people will base it on 120 divided by 3 and they'll end up with 40. The other mistake is people divide by 2 instead of 3 and get 60. That's what you do if you're putting them on morphine via injection rather than diamorphine. Morphine by injection is twice as powerful as morphine orally. Diamorphine is about 3 times as powerful. So for diamorphine, we're going to divide by 3. So 240 divided by 3 gives us 80. So C is the right answer. And this table for converting to a CSCI is continuous subcutaneous injection, okay? So a syringe driver, it's subcutaneous, isn't it? All right, but that's what CSCI stands for. Very commonly used near end of life because you get a higher concentration of analgesia in a smaller volume because it's more powerful than morphine, okay? So what you do is you calculate the 24-hour oral morphine requirement, including any breakthrough doses. So this patient was well controlled, right? Let's say that they'd had this 120 BD and they'd needed some breakthrough doses. You'd add that to the total. So in this case, they didn't need any more, so that's 240. And then this is the table taken from the BNF for conversion from oral morphine. When you're going to a syringe driver, if it's morphine, you half it. If it's diamorphine, you divide it by 3. Okay, so 240. If it was morphine, it'd be 120. Diamorphine, it's 80. Okay, this is extended matching questions come in sets of 2, 3, 4 or more. So you can see this is genetics 1 of 2, question 7 overall so far. Key thing here is that both parents are carriers for hemochromatosis, and what they want to know is the risk that their children will have the disease, not be carriers like them, but have the disease. What's the inheritance mode of hemochromatosis? Autosomal recessive, right? Okay, great. That's why the right answer is C, 25%. Both parents are carriers. There's a 1 in 4 chance that you get the faulty gene, the hemochromatosis gene from mum and dad, and you end up with full-blown disease. Whereas the second one in the set was asking, what's the risk that their children become carriers like them? That's a 50-50 risk for an autosomal recessive condition where both parents are carriers, okay? If I show you that visually, it becomes easy to remember. So look, mum's got a hemochromatosis gene and a normal healthy gene. Dad's got a hemochromatosis gene and a normal healthy gene. They're both carriers. You get one from mum, one from dad, right? If you're unfortunate, you get hemochromatosis from mum and dad, you have HH, and therefore you'll have full-blown disease. There's a 50-50 chance that you get a H gene from mum or dad and a normal gene from the other parent. So 50-50 chance that you will become a carrier just like they are. And then there's a 1 in 4 chance that you're fortunate, you get the normal gene from mum and the normal gene from dad. You're not a carrier and you can't pass it to the next generation. Okay. So 50% that you become a carrier, 25% you'll have full-blown disease, 25% that you're a healthy non-carrier. It's also worth knowing the modes of inheritance of the relatively important and common genetic conditions for the UK population, and I've listed them here. Okay. Question number 9, oligomenorrhea. Now, I want to highlight something important about technique. The majority of questions in the AKT are positively framed, just like the majority of questions that we've seen today. they're asking what is the right diagnosis, what is the right management, but you might get in the whole exam a handful of questions that are negatively framed. You won't get loads. There could be a few. You can see here, in this case, the negative word is highlighted. It's in bold. Sometimes it'll be underlined. Sometimes it'll be capital. Sometimes it won't be highlighted in any way. You've got to read carefully. The other thing that makes this challenging is that it's a multiple best answer. It's asking for 2, and you have to get them both right to get the mark. If you get 1 right and 1 wrong, you get nothing. Okay? So which 2 of these would not be recommended as part of a diagnostic workup for this patient? So the first thing is to look at all of this information and ask, what is the diagnosis that we're looking to exclude or confirm? Type that into the chat. What is it that we're trying to diagnose? Why are we doing the test in the first place? So some really important things here in looking at that. The fact that they're under 40, that they're still having periods. While they're erratic, they are still having periods. You can see, so this is not the menopause, is it? Someone's had the menopause, they will have no period for at least 12 months. Okay. But look, they have had periods that aren't that frequent, then it stopped, then it restarted, and it's erratic. But they've also got things like mood changes, all right? And some other important things, no regular medication. So what are we looking at here? What we're looking at is premature ovarian insufficiency, okay? And so what would not be part of the diagnostic workup for this? Correct answers are A and H. It's not recommended to do a pelvic examination, and it's not recommended to measure AMH, anti-Mullerian hormone. What often happens with this, most people pick H, a lot of people don't pick A. And so if you get 1 right and 1 wrong, you get nothing. There are no half marks in the AKT, all right? And sometimes people miss that it's negatively framed, and therefore they, pick completely different options, okay? So when to suspect premature ovarian insufficiency or premature ovarian failure? Under 40, not on the combined pill, and they've got menopausal type symptoms. So that could be things like infrequent or irregular periods, or periods that stop for a time and then come back. They might have raised FSH, so 30 international units per litre on 2 different samples, at least 4 weeks apart. And then other things that you might do, LH, estradiol, prolactin, TSH, testosterone. The guidelines specifically says not to routinely perform a pelvic examination and not to use AMH testing as part of the diagnostic workup. Okay, so sometimes people, miss the likely diagnosis, don't know the guidelines, so aren't sure what they should and shouldn't be testing. But sometimes people have the knowledge, but they miss that it was negatively framed. You shouldn't do this and you shouldn't do this. All of these are part of what you would do as part of the diagnostic workup for premature ovarian insufficiency. Okay. GMC guidance is part of the admin domain. So again, it's a multiple best answer. So we've got a £25 gift voucher from a relative of someone that we cared for. Okay, it was their mum. So which 2 of these are correct? B and F. Unsolicited gifts from patients or relatives may be accepted in some situations. And there's no maximum value set by the GMC of a gift that can be accepted. Common mistake with this one. So a lot of people pick E, gifts with a value of £100 or more need to be reported. And that's because they confuse GMC guidance with GMS, which is one of the types of NHS GP contract, the General Medical Services contract, the most common NHS GP contract. And GMS regulations, i.e., if you work in a GMS practice, then part of that contract states that gifts with a value of £100 or more should be registered in a register of gifts held at the practice. That's got nothing to do with the GMC, which is what this question's about. So again, reading the question carefully as well as having the knowledge is important. So let's look at what the GMC says. It says that you're not allowed to encourage patients or their relatives to give gifts to you or your family. You shouldn't pressure them to make donations, even if it's to a charitable cause. You're not allowed to alter the management that you offer or the services the practice provides based on gifts. And you shouldn't take a gift that might be seen as taking advantage you've got someone with advanced dementia, don't accept a gift from them, even if it's something small, because they might not realize, they might not have full capacity and be truly giving it voluntarily. They might feel they have to pay you. Now, if none of those apply and someone voluntarily offers a gift, like in this situation, you can accept it. And they don't specify a maximum value. Now, nothing to do with GMC, but if you're working in a practice that holds a GMS contract, which most of you will be, because most GPs work in a GMS practice, that has within it a clause that gifts worth £100 or more must be recorded in a register of gifts held at the practice. Musculoskeletal. Okay, so key things here is that the small joints of hands and feet are affected. So we've given them painkillers, we've ordered relevant blood tests. What's the appropriate next step? The answer is A. Because the small joints of the hands and feet are affected, this is one of those situations where they need a very urgent referral. Within 3 working days is what the guideline says. So A is the right answer. Common thing, people pick 3 weeks. Okay. That's because anyone with suspected rheumatoid should be referred to a rheumatologist within 3 weeks. That's the default position. But those that should be referred even more urgently within 3 working days include those like this patient where the small joints of the hands or the feet are affected. In this case, it was both. Or if multiple joints are affected, or if by the time you see them, they've already had symptoms for 3 months or more, because that suggests that they've already got significant disease progression. So the quicker we can get them onto disease-modifying anti-rheumatic drugs to sort of slow down that progression of the disease, the better the outcomes. That's why you don't delay. You can order the blood test, but don't wait for the results. Okay? Alcohol intake. So there's 2 ways that you can calculate units of alcohol. So one is, if you just learn off by heart how many units are in common drinks, sometimes you can sort of estimate it close enough in your head to get the answer right in the exam. The other is to use the formula to get the exact number. I'll show you both methods, okay? So the correct answer is D, 27 units. And that's because how many glasses of wine is this patient having in a week? 9, right? I eat 1 every night, so that's 7 nights. But look, on Saturday and Sunday, she has another glass for lunch. So the common mistake is people just look at the number, they don't read the whole scenario. So they'll do 7, and they know that a large glass at around this strength is 3. So they do 7 times 3, they get 21. That's the common mistake. If you calculated that it's 9, you read the whole scenario, then you know that it's 3 units in a large glass of wine of about this strength. This is a sort of medium strength wine, okay? Then 9 times 3, 27. I'll show you the way to get it exactly. The formula is units is the volume in milliliters multiplied by the percentage alcohol by volume. Take that total and divide it by 1,000. So we've got 250 milliliters multiplied by 12%. Okay. And you take that total. So if I show you on a calculator, 250 mils multiplied by 12 is 3,000. Okay. Divide that by 1,000, you get 3 units exactly. Okay. So divide that by 1,000, gives you 3 units for each glass. 9 glasses, 9 times 3, 27. Okay, so D is the right answer, 27 units. And this is how many units of alcohol are in common drinks. So wine at about 12%, small glass, like the kind that people might have in their house, 125 mils, 1.5 units. A large glass, like ones you have in a fancy restaurant, that's 250 ml glass, is 3 units. Standard strength beer is about 2 units for a pint. That's about 3.5 to 4% alcohol by volume. Premium beers and lagers, 5 to 6% alcohol. A pint's about 3 units. Cider similar to that. Spirits, 25 millimeters, sometimes described as a single shot of any spirit at 40% strength. That's the most common strength of spirit sold in the UK, is 1 unit. And the other way is to know the formula. So units is the volume in milliliters multiplied by the percentage alcohol by volume. Take that total and divide it by 1,000. That will give you how many units is in that drink. And then count up the total. Diabetes management. So we've got someone with poorly controlled diabetes. They're already on triple therapy. So we're now thinking about moving them across to insulin. What would be a suitable regime? Correct answer is B. Okay. As an initial regime, i.e. a starting regime, I'd stop the sitagliptin, stop the pioglitazine, carry on metformin as a baseline, and put them on an intermediate insulin like NPH, neutral protamine hagedorn. Okay, this is derived from fish protein. And so, like, typically I would put them on this as a once daily dose, giving a baseline level of insulin. I'd give this in the evening normally. And then they carry on with their metformin, and then you see how they get on by measuring sugars sort of morning and evening, how they're getting on. And if necessary, you could go to twice daily, because this is about an initial regime. Can you see? Sometimes patients will need a baseline and then have a bolus dose around meal times if they're still poorly controlled. Okay, but as a starting dose and a starting regime, this is a good start. So NPH is an intermediate insulin. You can start it once daily or twice daily. So if it's once daily, it's normally given in the evening. If it's twice daily, then it's morning and evening. Continue the metformin. Generally, I'd stop the others. Okay. If they had even worse control, so this patient's HbA1c was 70. If it was 75 plus, I might go straight to NPH plus having short-acting insulin. And then when might you think about long-acting insulin? So things like insulin detamir or glargine instead of an intermediate one like NPH. If they struggle with the injection, so they need help, maybe a carer comes in, okay? Or if they get recurrent symptomatic hypos on an intermediate one, you might think about moving on to a long-acting one. When they go onto an insulin regime, we need to measure their blood sugars morning and evening, see how they're getting on. If they're not well controlled, they might need additional support around meal times. Okay. Question number 14. So before we go on to that, a couple of people have asked that, do GPs start patients on insulin? Is that secondary care only? When I was newly qualified, I'm talking about 2007, almost everyone with a new diagnosis with insulin would go to see a consultant endocrinologist or consultant general medical physician. There are very few of those left nowadays, and they'd be started in hospital and clinic. Now, this is absolutely a GP skill. Okay, this is very commonly done in GP. If you've got someone who's poorly controlled or they're struggling, then they're going to get referred on. But a lot of patients now, we will manage and initiate insulin in primary care. Okay. So this one is an example of a free text question. So with these, you would type your answer into the box in the actual exam. There's no options of A, B, C, D, E. So type your answer into the chat. Okay. Okay, so we've got answers ranging from, the lowest is 0.027. The highest is 41,560. And we've got lots of answers in between. So we've got 4, 41, 27,000, lots of other answers in between. The correct answer, and the only one that would get you the mark, is 41,560. Okay. If you put the comma or you don't, doesn't matter, you get the mark. But that's the only actual number, and that's because the question is asked to the nearest whole number. Okay, let me show you the calculation, and then we'll look at why people might have got it wrong. All right. So this question's asking about incidence. All right. So incidence is the number of new cases of a disease as a proportion of the population. So in this case, it says per million people. And the reason for that is, do you remember at the time of the pandemic, they were showing sort of, outcomes in different countries. The WHO asked all countries for standardization to report incidence per million. Okay. And so we're just taking it because that's the format that public health data was presented for COVID. So first thing is incidence is, how many people had it? So there were 2,770,000 cases. This is irrelevant. If the question asked about mortality, then we'd care about COVID-related deaths, right? The question isn't about mortality. It's just about incidence of COVID-19. So that's the number at the top. That's the number of cases. We're going to divide that by the population, which we're given, 66 million and change. This is 2020. It's gone up since then. We're at 70 million plus now. Okay. That gives you this number. Those of you that put 0.04, you stop there. Those of you that then decided to multiply by 100, you could do that by moving the dot 2 places. Those that picked 4 or 4.1, what you've done is you've calculated the percentage, but the question doesn't ask you to calculate the percentage. Any incidence is given as a proportion of the population. Percent, the proportion is per 100. That's all percent means. It means per 100 people, okay? But in this case, because we're multiplying by a million, not by 100, because we want it per million, once we multiply this number by a million, we get 41,560.39. And the question said to the nearest whole number. So how do we calculate to the nearest number? After the dot, you look at the first number. If this number is 5 or more, you'd add 1 to this. It would be 41,561. If this number is 4 or less, then this is the nearest whole number. So because this is 3, the nearest whole number is 41,560. Okay, so those are the steps that have let us get to this. All right, so let's recap incidence. It's the rate of new cases of a disease. So you can report it as a percentage or as any other proportion of the population. A percentage just means per 100. Okay, and we look at it generally over a year. So 1% per year means 1 in every 100. For things that are rarer, we might report it as per 1,000 or per 10,000 or per 100,000. For example, 2 per 100,000 per year, rather than 0.002%. This is very difficult for a lot of patients to get their head round, but a whole number like this is easier. So what you do is you take how many cases, new cases there were, divided by the total population, and then if you're going to express it as a percentage, you'd multiply it by 100 because percent means per 100. If it's per 1,000, you'd multiply by 1,000. If it's per 100,000, multiply by 100,000. This question was per million, so you multiply by a million in this step. You're always going to multiply by something, okay? By per however many it is, right? So that's why we got 41,560. So there's both the knowledge of incidence and how to calculate it, and there's the technique of reading carefully that it's per million and to the nearest whole number. Those 2 bits there to get the right answer, okay? Right, last one, prescribing in pregnancy. And this is testing being up to date with MHRA drug safety alerts. So I've got this lady who's in the 2nd trimester of pregnancy, use some ibuprofen. What should we advise about that? The correct answer is that additional monitoring might be required if NSAIDs are used from week 20. Okay, this is based on a recent MHRA alert. So for a long time, decades, NSAIDs have been considered contraindicated in the last trimester, specifically 28 weeks onwards. The risks are it can lead to closure of the ductus arteriosus early, renal dysfunction in the fetus. It could increase maternal bleeding time, therefore increasing the risk of a postpartum hemorrhage. It can inhibit contractions during labor, making that more challenging. So in terms of drugs, it's a class effect. So really any NSAID, oral, injected, doesn't matter. So ibuprofen, naproxen, diclofenac, any NSAID really. But the recent data highlights that there's an increased risk with prolonged use of NSAIDs from 20 weeks, i.e. a lot earlier than we previously thought. And so the MHRA put out a drug safety alert that because prolonged use can increase risks of reduced fluid and constriction of the ductus, which can lead to heart dysfunction, that we should consider antenatal monitoring for oligohydramnios if they've been exposed to NSAID for several days at any point 20 weeks onwards. And we should avoid prescribing. Previously, it was 28 weeks. Now, from 20 weeks onwards, we shouldn't prescribe any NSAIDs. We should advise patients not to take them over the counter as well. Okay, so add up your score. You get a total out of 15. So we did 5 one at a time and 10 in the mock. You get a total out of 15. Now, I'll tell you how to interpret that. So you've got 11 or more. That's a pass. What you want to do is look at the marks that I lost. Did I lose it because they're topics I haven't covered, or did I lose it because of exam technique, or is it a bit of both? If you've got 10, that's borderline. It would be a fail in most sittings. It would just about be a pass in sittings where the pass mark was set right at the bottom end of the scale. If you've got 9 or less, don't worry. You're not sitting the exam next week. All right. You've got still 7 weeks between now and the exam. All right. So you've got time to address those gaps. And again, you want to look at whatever your score was, any marks you lost. Did I lose them because I haven't covered that topic yet? Or I've covered it, but I missed that bit of detail? Did I not know that this guideline had changed? Or was it that I missed something in reading the question or reading the answer options. Is it my exam technique or is it a bit of both? And then you've got time to work on it. Okay. So let's talk about revision planning, how to make the most of the time between now and your exam. So we've got 7 weeks, and especially the last 6 weeks to the exam. That, by that stage, you should have covered a good chunk of the curriculum. And what you're going to do is you're going to systematically cover any gaps and any areas you're less confident in. As you get close to the exam, the last 2 weeks, you want to go over, you will have already covered by that stage all the key topics in stats, admin, clinical, but you want to revise those again. All right. The last month before the exam, go through one each day, our AKT 30-day challenge videos. They're on our YouTube channel. Each one has like a question to time and then a rapid review covering knowledge and technique. So it's a nice way, just in sort of 10 minutes a day, that you cover 30 topics, some clinical, some stats, some admin, as a way to boost your knowledge as you get to the exam. And then work on exam technique. So, continue practicing your questions. As you get to the closest period, the last 4 weeks, I recommend doing one full mock every week on the weekend, as you come up to the exam. So, if you can do that, 2 time conditions, you build up your stamina, you get used to managing your time, you can still identify gaps that you need to fill, and you've still got time to go over and in a focused way, cover those gaps. Okay. So in terms of covering the checklist, we do have a curriculum checklist where we've actually made a sort of printable checklist covering sort of the just under 600 topics that you need to have covered the breadth of the curriculum, split into clinical, stats, and admin. And then we also have a high yield checklist. You can't just learn these, but these cover the topics mentioned by examiners in their reports recently. These topics get tested again and again. So there's a good chance that these are going to come in the exam. Okay. In terms of reading, if you've got a specific guideline that you want to look at, you might look at the NICE guideline for that, or NICE CKS. All right. By the way, the NICE guidelines and NICE CKS are slightly different in some cases. That's because NICE are the people that publish actual guidelines. NICE CKS is run by a private company and they summarize NICE guidelines. Sometimes there's a difference. And the examiners have highlighted that if there's a difference between the actual NICE guideline and what NICE CKS says, the source for the exam is the actual NICE guideline, not NICE CKS. Okay. But if you want to cover lots of clinical topics quickly, if you haven't already got our clinical case cards, that's a quick way to efficiently cover lots of topics. There's 112 topic reviews. They're updated at least once a year. And so, it's a quick way to cover key information pulled from NICE guidelines. And then, how we did that mini mock, 10 questions in a go. Our AKT 200 mock crammer, that's how that course runs, where we do a 50-question mini mock. And in that mini mock, 80% of the questions are clinical, 10% is stats, 10% is admin, just like the real exam. You do 50 all in one go. Then I give you a topic review. I go through answers, explanations, and teaching. Then we have a break, then another 50, then lunch, then another 50, then a break, then another. So by the end of the day, you do 200 questions, more than 200 topics, rapid reviews. You have a PDF course booklet, so it's easy to read back afterward, access to the recording so you can watch it back again, and then you get access to a different full mock with 200 different questions to then make sure you're exam ready. Okay. And we have some of these different things that are coming, these live sessions that are coming, the AKT 200, the stats, the admin, the high yield clinical crammers. We have them coming up in bundles that are discounted. So our AKT Plus bundle includes our full day AKT course that ran last weekend. The recording of that is now available. Our AKT 200, the stats, the admin, the high yield clinical, all of our online questions and 3 full mocks at a discounted bundle. Our AKT Booster bundle includes the AKT 200 stats, admin, and the high yield clinical, and access to 1 mock B, 25 hours of learning there. And then the masterclass bundle just includes the webinars, stats, admin, high yield clinical 1 and 2. Doesn't include any additional online questions or mocks. All of those are discounted compared to separately, but all of these are available separately. Okay. And the live sessions for July, again, if you're on the Pass Plus or Pass Guarantee, you're already booked for all of these. If you're not, you can book the booster bundle to join all of these live and get access to the recording. So 31st of May in the morning is stats, 9:30 a.m. to 1:30 p.m., 4 hours. 31st May, so that same Saturday in the afternoon, 2:30 p.m. to 6:30 p.m. is admin, half day. And then Wednesday and Thursday, 4th and 5th of June, 7 p.m. to 10:30 p.m. each evening. So 3.5 hours each evening, High Yield Clinical 1 and High Yield Clinical 2. So these are clinical topics mentioned by examiners, 100 questions across the 2 evenings. And then Saturday, 14th June, a few weeks before the exam, getting your exam ready, the AKT 200 mock crammer, 200 questions in one day, and then another 200 online questions afterwards to consolidate your learning. Okay, so all of those are available as part of the booster bundle for £495. It's over £200 saving compared to if you booked all of those things separately. Okay, I want to leave this message for those that haven't got questions, that look, when you get this close to the exam, I want you to think about what Muhammad Ali said. Don't count the days, make the days count. Between now and the exam, there shouldn't be a single day that goes by where you are not learning some new knowledge, not revising something, where you're not doing some questions, you're not working on knowledge and technique. You should be doing something every day that takes you a little bit closer to your goal, that improves your knowledge, that improves your technique. You're doing some questions, you're revising some guidelines, you're reading over some of the notes that you already made, you're doing something that takes you a step closer to getting that big green tick and passing your exam. Okay, so just make every day count. It's been really nice weather recently, and so there might be days where, you know, it's a sunny day, VTS gets cancelled. Do a few questions and then go for a walk in the park. All right, you know, you have a patient that doesn't attend, you've got a 10-minute gap. Don't go on TikTok. Don't go on, you know, Reels and Facebook and YouTube and watch nonsense. Do a question. Revise one case card. Read over one note. You know, do something that will help you get to exam readiness. Because if you can do that, if you can put in the effort, make those sacrifices, you will be prepared and you will pass. Because prepare and you will succeed.